Welcome to everybody to the Public Health Nursing webinar. I think I finally stopped saying ITV after how many years since it hasn't been an ITV. We have a few people in the room today. We have a couple of presenters that are going to be remote, so they'll be calling in. I hope everybody, if you didn't check your email this morning, we do have, and for you in the room, we have a stack of agendas there for you to look at. But Deb did send out agendas today. I apologize for not getting this out sooner, just as I want to apologize for not having nursing credentials for this. Since this is one of my other duties as assigned, I've got a lot of things going on, and so getting the agenda together and the speakers has been the best I've been able to do up until this point. We will work very hard for October to get your nursing CEUs, because I know that is important, and I do apologize for that. So it's a process, as you all know, and we're working on that. We are going to have our first speaker today. I want to go ahead and get started, and we've asked Chang Lee to come and talk about expedited partner therapy. Many of you know this is something that when I was not even in the department working with Kentucky ACOG, getting expedited partner therapy was very important to me as a clinician, and so I'm very excited that we're able to roll this out. And as I've said before, I have called South Carolina's Deputy Commissioner of Public Health and said, you're going to be the only spot on the map. So I just wanted you to know that, and he's thanked me profusely for sharing that information with him. The one issue that I wanted to talk about before Chang gets started is I know that there have been concerns with some of the local health department nurses, because in our guidance it says that if Connie White is the patient and I see her and she gives me 2 contacts that need medication, you as the provider would write that prescription if that person has insurance, or give them the medication provided by the state program if they don't have insurance coverage. And we have asked you to document that person's name in your chart. Several nurses have been very concerned about that because they said that it's against the nursing license for them to do that. So I called Jessica Estes, who is the new executive director for the Kentucky Board of Nursing, and she said the same thing. Oh, I don't think you can do that. Now, as a physician, I wouldn't have hesitated to do that. So I thought, well, maybe these are some nursing rules and I'm just not comfortable with or familiar with. So Jessica then worked with their attorney. They looked at all the statutes, they looked at all the regs for nursing. There is nothing in the nursing regs that say that you can't do that. So the real issue is the concern of, if I release my medical records to another provider, my medical records will have someone else's name in the chart. Has that person given permission for their name to be released? That can be taken care of by making the STD visit a protected part of your medical record. I think we probably, and I don't know this, have something in the AR that says you can't put another patient's name in the chart. So the expedited partner therapy program has kind of opened up an issue that we've never discussed. So the Nursing Executive Council will be meeting on August the 27th. And I'm going to bring this up at the meeting for us to look over this and figure out the real issue is, how do we protect that contact person's name that's in the chart? I'm, as a clinician, thinking, how can I write a prescription for someone if I don't document that person's name in the chart? So it's a little bit more, it's a little bit complex, but in another way, it's rather simple, that we just protect the STD part of the patient chart. So we'll talk about this on the 27th. We'll have some information for you about this in our October webinar, and we will probably have some communication with you before that, after the NEC meets and comes up with their ideas and figures out how we need to approach this. Having said all that, this is to tee up to introduce Chang Lee, who's going to review with us the new changes in the CSG. It is the CSG now, not the CCSG. With public health transformation, it's not the core clinical, because there are things in the CSG that are not part of the core box of the public health transformation. So we altered the name a bit. So I want Chang to come up here and just go over why we changed this with the EPT regulations and how critically important it is for the women in the state of Kentucky. So Chang, you want to come up?
Thank you, Dr. White.
And let's make sure we don't just have your nose.
There we go. Thank you. And how do I move the slide, Dr. White?
Okay, you click on this.
Oh, okay.
You can't see you now,
I prefer that actually.
but they can see you.
Actually, the slide that I'm presenting is the exact same slide I presented back in June 22nd when we had the same meeting. So I'm assuming at this time I'm addressing some different folks, but it's the same information. This is the exact same information that's going to be in CSG. And I had not changed. No, I did change it. Okay. What is the expedited partner therapy? EPT is a clinical practice of treating the sex partner that was diagnosed with GC and chlamydia, and is giving that patient's sex partner or partners a medication to treat those diseases without first them being provided with a clinical service, like being examined by a physician. And why is this expedited partner therapy should be a critical element of STD service? CDC estimates that only 29 to 59% of patients of STD are told to notify their partners and actually carry through with that request. Because of limited staffing, partners of a patient with GC or chlamydia are less likely to be contacted and treated. For example, here in Commonwealth, last year we received a little over 27,000 cases of chlamydia and 5,800 cases of GC. And we have 11 DIS, disease intervention specialists. And since their primary focus is on investigating infectious syphilis as a primary, secondary syphilis and congenital syphilis and newly identified HIV, they simply do not have the resources and time to investigate those CT and GC cases. Only in a rare occasion when they have a high-risk individual, such as a person that's pregnant, with other additional high risk, multiple partners, those who's been previously diagnosed with HIV, for example, they get initiated for investigation. Otherwise, we verify the treatment if we can, and we just enter into the system on a weekly basis. We send that information to CDC, and that's all we do. It's a passive surveillance, not an active surveillance, and we don't hardly ever do investigations. So rate of infection, reinfection for those individuals with GC and CT is quite high. And that's one reason EPT comes into place. And studies have shown that EPT is an effective option to treat partners, prevent reinfection, what I just talked about of index patient. In Louisville, we have a standalone specialty clinic, only one in the whole state that is do nothing but STD services. The rate of reinfection for some of those individuals that comes in the clinic 4 times a year for exact same STD, same GC, 4 times a year, same CT, 4 times a year, averaging almost in 5 years span. When we looked at this back in 2015, one person came to that clinic almost 18 times in that span for same exact exposure or disease. So EPT is not going to eliminate that whole process, but it's going to help reduce that number of same individuals coming into the clinic for same exact thing. And it slows and stops the transmission to other uninfected partners, thus breaking the cycle. And lastly, saves money to reduce the treating more advanced diseases, such as PID. Average cost of someone that has PID who has to be admitted to a hospital from 2012, so his data is kind of dated, but it was about $220,000. And partners are considered that those index patients have sexual contact within the last 60 days. So anybody that person claimed to be had a sex with within 2-month period, more or less, is eligible for EPT. STD reinfection is common. Reinfection rates among women with treated for CT, 15% comes back within 6 months. 30% comes back within 12 months. Reinfection rate among women treated for GC, 14% in 6 months, 27% within 12 months. Reinfection rate among men with both CT and GC, 15% in 6 months, 21% in 8 months. This is the map, and again, on that, if you read this slide on the top, Kentucky will become green as of July 1, 2019. So as of now, all the states basically provide EPT service. except for one little state right there, South Carolina, the person Dr. White called. So we are the 49th state. I don't have information on the Commonwealth, such as Puerto Rico and territories like Virgin Island and Guam, places like that.
Puerto Rico's on there.
Puerto Rico is on there. Oh, I'm sorry, I take that back. But otherwise, we are now fully in the process of implementing EPT. We already had medication requests to send those out, so we are in the thick of it now. So we were next to last, and we're the 49th state, and there are some states that has in between, like South Dakota, Kansas, Oklahoma. For example, Oklahoma does actually allow EPT, and I don't think they have made it into like official status, but even when I was there back a long time ago, they were doing EPT. Special population and EPT. Adolescents have the highest rate of infection for all age groups, and they are the priority. MSM patients should have a full STD exam because of likelihood of prevalence of comorbidities. We don't recommend EPT for MSM population for that very reason, because we prefer that population to come in and not just get screened for CT and GC, but also for syphilis and for HIV. And for that reason, EPT is not recommended for that population. And pregnant women need to avoid reinfection. Rescreening for chlamydia after 3 to 4 weeks is very important in pregnancy. Missed opportunities when using EPT. This is some of the cons of having an EPT. I'm a big proponent of EPT, but I don't want to just talk about all the positive elements of EPT. There are some aspects of EPT that some people might find questionable, because here, inability to diagnose and treat co-infection. Because that patient is not going to get seen by a clinician, that patient only going to get medication for GC that his or her partner was diagnosed with it, or for chlamydia. Missing complicated infection, e.g. PID, pregnancy, testicular pain, abdominal pain, etc. Lack of risk reduction counseling, because they're not going to speak to a clinician or a nurse or DIS even for that matter. All they're going to get is the medication. So there is the educational component that's not going to be there with EPT. And inability to evaluate the risk of a sexual exposure, because that medication is given by the person's sex partner. Obviously, that component of counseling is not going to take place. Cost of STDs. STD costs of U.S. healthcare system estimated $16 billion annually. A single oral pill treatment for chlamydia infection costs about $10, while treatment for infertility can cost thousands of dollars per patient. Single oral pill for treatment of GC costs $18, while treating PID costs over $2,000 per patient. Yes, Dr. White. Oh, I'm sorry. Kentucky STD prevention program will supply local health department with the medication for EPT. Local health department may provide written prescription for index patients to take to the partners. Prescription will be written with partner's name. DIS may deliver medications if needed. Summary of CDC's EPT for management of STDs. EPT was effective in reducing persistent or current infection due to CT and gonorrhea. EPT was associated with higher likelihood of partner notification and partner treatment. Preliminary economic analysis suggests that EPT is cost-saving and cost-effective partner management strategies. EPT represents an additional strategy for partner management that does not replace other strategies. And this is the treatment for GC. We have sulfexamine and Zithro, and chlamydia zithromycin 1 gram. We have sulfexamine in stock now. This is the part Dr. White was referring to, so I'm not going to discuss this at this time. So we can discuss it at the next one when we have more additional information, so I'm going to skip this part. And that's it. I'm going to answer some of the questions. Not that I can. When you state provider, Are you referring to our mid-level APRN, or are you stating that LHC nurse should hand out masks per the CSG protocol? Answer to that question is yes, you can. When is order form for Sufexmy going to be sent out? You don't need to have an order form. You can order that medication just like you have done previously when you need STD meds from us. When you order Zithro and penicillin, for example, Pam Young is our person, a dedicated person who's going to be distributing STD meds. So you can just call our office and request it, or just send Pam email, and I will send that to Deb, and so you guys can have her email, and you can just request it through her. Rather than writing a prescription for those with Medicaid, could we give it to LHD and bill Medicaid? That is an option you can utilize. You can definitely give out the medication, but the medication that we're going to be sending you guys is a free for you. You don't have to. There's no charge, so you don't have to bill Medicaid. Sufexmy and Zithro are both free of charge, and we have been giving out Zithro for years and years, so that's not an issue. Sufexmy is something new. We don't use Sufexmy for regular patients who come into the clinic because it's not a recommended treatment. But for EPT, it is. So we just got those in. Again, it's the same process. Just call us and we'll ship it out to you. That's it.
Okay.
So you already addressed?
Yes. Okay. All right. So if you have further questions, you can always send them to me and we'll make sure that they get addressed. And as you said, as I said before, this is a work in progress. So we're in the process of getting this taken care of. But thank you for those of you that are interested in providing the service. I saw plenty of pelvic inflammatory disease in my life as an OBGYN physician and took care of a lot of those patients, and unfortunately operated on a lot of them after the fact. All the financial that Chang talked about, and then I was, as an OBGYN physician, I saw the physical toll that infertility and that chronic pelvic pain took on those patients. So that's why this is so important to me. All right, we're going to change gears now, and we have asked Nicole Nicholas to come. She has some WIC updates. I would like to congratulate her because she was able to submit the WIC state plan yesterday, one day early.
Yes.
When I first got here in the commissioner's office, they brought the state plan for me to review because I said I wanted to read everything that I signed, and they brought it down in a cart. And it was 5 volumes that were about this thick. So the state plan is no small deal. So I know she's coming down off of that high
Yes.
of releasing the state plan, but we've asked her to come and give us a few minutes, and you have 20 minutes to talk
Okay.
about WIC updates, and I'll raise my hand when it's 5 minutes.
Okay, thank you.
Thanks, Nicole.
Hi, okay. I wasn't sure if I would show or not, but we might need to lower it just a little bit.
Sorry, I thought we were the same height.
Yeah, I'm short. Well, thank you for having me. It's my pleasure to be here, and I appreciate the opportunity to give everyone a little bit of a WIC update. As Dr. White said, we have been extremely busy in our office getting ready to submit our annual state plan to USDA. And this year, there were lots of changes, but I'll get into. But I do want to start out. I don't have a presentation today. My name is Nicole Nicholas, and if you do need to email me, you can at Nicole, Nicole dot Nicholas, Nicholas at ky.gov. Currently, my computer is not working. I spent about an hour and a half with COT yesterday. I can't get my emails, but I will respond. But just so you have a sense of that. I like to say, and I've been telling our WIC staff in the state office, that WIC is in a renaissance period. We are really rebuilding and reimagining the WIC program, and it's a really exciting time for us, a very busy time, but a really exciting time for us in WIC. You may or may not know, but the WIC program is celebrating 45 years this year. So the WIC program is 45 years old, and the WIC program started in Kentucky. The very first WIC clinic was in Pineville, Kentucky. So Kentucky has a really strong history with the WIC program. It's a valuable program, and we're really excited to be continuing the program and reimagining the program. So with that renaissance, what am I talking about? We are reviewing every policy and procedure that we have. We're looking at the federal regulations. We're looking at USDA policies. We're looking at Kentucky regulations. We're looking at policies and procedures other states utilize. And we're saying, okay, where are there barriers? Where have we maybe possibly as a state agency created some barriers that are making it more difficult for participants to access the program, or for our local health department providers to provide the program? And we want to see where we can try to eliminate some of those barriers, because we want to make sure we're serving the maximum caseload that we can, and that we're making a difference in the health of our women, infants, and children in our communities. So we're really excited about all the work that we're doing with that. And I'm really excited to share with you all that the last 3 months, we have been on a trend of increased participation. Yes, small, modest, but we're moving in the right direction. We've been saying for a while, because it's a national trend and a Kentucky trend since about 2014 or so, that we've seen a decline in the WIC participation. And there for a while, we're like, we got to get participation up. We got to get participation up. And then we're like, we got to maintain. Well, we are actually increasing modestly in the last 3 months. So I am super excited about the work that you all have been doing in the local agencies to get our participants seen and get benefits issued. So those kudos really go to you, because you all are doing that work. So I appreciate all the work you're doing, and we're seeing it on our end as we track those numbers. So congratulations on that. So I will get back a little bit to our renaissance. We did send out, we were able to obtain some operation adjustment funds, and your WIC coordinators and your administrators should have received an email probably in July, 1st of July, that there's some funding to purchase some computer equipment, to upgrade some of your equipment, and some additional funds just to help with participation. Whether that means reaching out to those that are not showing, having staff do that, going to health fairs, doing some additional outreach, having some longer hours, whatever, it's up to the local agency. And those were just for July through September, but just to try to, again, get that participation up. And so they were notified that in July, and have some additional funding for that. And if you have questions about the computer equipment, you can email our office, Deborah Hauk, or Kathleen Logston, process all of our equipment requests and funding requests for the WIC program. So now I'll get back to a little bit about sort of the renaissance and the policies and procedures. There's some changes that are coming. Some of you may be at local agencies that are currently using our online nutrition. Some of you may be agencies that are wanting to utilize the online nutrition. We have been working this summer to get our WIChealth.org, which is our online nutrition provider through Western Michigan University, integrated with the CDP MIS portal CMS system. And so that's really close to happening. And once that's integrated, you will be able to access a report of participants who are eligible for online nutrition education, and you'll be able to see right in their household whether or not they actually took a course, and what course they took, and what date they took it. So for those of you that currently have the program, there's going to be lots of great enhancements to that. There's going to be a label that you can print out and just put in the chart to document what they took and the date that they took it. For those who don't have it yet, we will be working on rolling that out over the next few months. And so you'll have an opportunity for your low-risk secondary appointments to offer them online nutrition. for participants, you know, if you imagine you're a mom and you've got 2 little ones, and rather than trying to drag them to the WIC clinic, you can get them to bed, you can sit down, take it on your phone, and take an online nutrition course at midnight if you wanted to. So we're really trying to reach our millennials with the online nutrition, decrease barriers with transportation, and that will also help with you know, administrative barriers in your clinic. So hopefully that will reduce some of the administrative costs for providing the program. One of the other things that we're doing is we will be rolling out this fall a 1-year certification period for our children. So that is going to reduce some of the barriers for administrating the program. We will still be doing a 6-month sort of health check, a mid-cert health assessment, where we'll still be doing heights and weights and finger sticks if needed, and a little diet assessment, but they won't have to bring in the proof of income. So we'll save some time up front with some of those barriers of proof. We are also developing additional group education curriculum. So if you find that it's useful to try to provide some nutrition education to a larger group for a little more efficiencies, we're going to have some additional group curriculums out there for you to utilize. We're also introducing telephone secondary nutrition education. You know, we can upload our benefits now. So we're going to have protocols. If USDA approves it, this is all part of our state plan. So I'm not going to get into too much details with all of these, but you'll have the opportunity that if there is a barrier to coming into clinic, and maybe you've got a grandma or somebody that doesn't want to do online nutrition, they don't want to have to log in and create an account and that sort of thing. They still want to talk to somebody, or maybe they have a question. A lot of our new parents really rely on you to answer some of their questions. So maybe they really want to talk to a person. You'll be able to do telephone secondary nutrition educations as well. We're also, we've had some feedback about the cost of the Pronto sensors with our, for our hematological screenings. So we are, it's still an option to use the Prontos. I know we've got a lot of positive responses about how much quieter our WIC clinics are when we're not doing finger sticks, so we don't have screaming children. But for some agencies who may find that the HemaQ, they prefer that methodology, both are going to be an option. The way it was currently written was that you must do the Pronto twice before the HemaQ for those that are 2 and older, unless there was an issue. The only time that we would ask that you definitely utilize the Pronto is if there's a consent issue or we don't want to do any sort of invasive. But I think there's some changes to the nursing regulations that made that consent may not be a barrier. But if there's a situation where you're unable to do the finger stick, we would still like you to utilize the Pronto. So it's going to be an agency choice on which technology they use to do that anemia screening. We have created a referral form for you to be able to share with the physicians in your office, in your communities, hospitals, and so forth, so that you can get additional WIC referrals, and we'll be sharing that once we get that approved. We're also going to be reviewing our monitoring schedule, and you may be seeing a little less of us, and you may be, but when you see us, you might see more than one person. We're going to try to coordinate our nutrition visit with our program management visit, so that we're taking up a little less of your time when we come out there. But we'll still be available for technical assistance. You can feel free at any time to call your monitors, whether that's your program management monitors or your clinical nutrition monitors. And if you want us just to come out and just do a technical assistance visit and walk through things, we are happy. We're here to support you. So please feel free to reach out to us. We're also reformatting our WIC nutrition manual. Now, most of the sections have been reformatted. There's a few that we're going to reformat next year, over the next year, but we tried to reformat the sections that most impacted you in clinic and your day-to-day operations. So you're going to see that the WIC nutrition manual looks a little bit different. We've numbered policies so that it's easier to find information, because what we were hearing was that I can't find anything in that WIC and nutrition manual. It's so large, it's so big. So we have separated topics by number, so it'll be really easy to go to exactly where you need to find information. And we have we've changed the whole formatting. We've given you a little more information about the overall, what the policy is, what the, like the rationale, why do we have this policy? And then what are the federal regulations or USDA memos behind this policy, so you can have a better understanding of sort of the purpose of the policy. So it's not just, something written in black and white that says you must do it this way. We hope that it'll give our local agencies and our state staff a better understanding of why we have our policies and why they're written the way that they're written. So I hope that you'll find that useful. Let's see. As Dr. White said, we have submitted our state plan yesterday. We're really excited about that. That took lots of work. Also, we're in the process of doing some WIC modernizations. We're doing some visits to some other states to look at some USDA approved state model of MIS systems. So you'll be hearing some more about that in the next year or two as we have opportunities to get feedback from our locals on our MIS system. I do want to also mention a few other things that we've done to try to reduce the administrative burden of the WIC program. We heard some feedback about our WIC Farmers Market Nutrition Program over the last couple of years, that program was somewhat time consuming to issue the benefits. So I hope everyone is happy for the agencies that are issuing those and participating in that program with the changes that we've made this year. We really do appreciate and listen to your feedback. What we've done is we've gone from 5 individual vouchers where you had to fill out a stub on each voucher and fill out lots of information directly on the voucher to a booklet, and there's essentially only one stub. So hopefully that has made it easier and less time consuming to issue those WIC Farmers Market Nutrition Program vouchers to your participants. We've also decreased the value from $20 to $16 so that we hope that we can serve more participants that way. And for those participants that are in areas that have the double dollars, you can double program, you can double $8 and turn it into $16. So for those that are in those communities, they have opportunity to get $32 worth of produce. So we're excited about those changes. We hope that those have really helped you in administering the program. Our vendor management team is out now. They've started in August with our annual training, and we have tried to take more of a leadership role in organizing those trainings so that there's less burden on your local agency and inviting all the vendors to those trainings. That's something that is federally required, that we do a face-to-face training with our vendors. And so at least, I believe that has to be at least it's either once every 2 years or once every 3 years. Kelly Darlin is our vendor manager, and she is our expert on the vendor portion of the program. So our staff has been hard at work and continue to be hard at work out across the state providing those trainings. And let's see. I do want to also just give you some more kudos about the WIC program, just so you know how important the program is and how your hard work makes a difference. In June of 2019, JMA research letter with CDC and USDA released information about WIC data and obesity. And you may know that from like 2000 to 2010, the national trend for children was we were seeing an increased amount of obesity among our children. Well, since 2013, our WIC children, we're seeing obesity rates drop. So you all are doing a fantastic job with your nutrition education and promoting the healthy foods of the WIC program, because we're seeing a difference. Also, I have to say that August is breastfeeding month, and we've got some positives there with breastfeeding as well. Our rates in Kentucky, although one of the lowest in the nation, have continued to climb. And so in the Kentucky WIC program, our initiation rates are now 54%, And statewide in Kentucky, our breastfeeding rates are 73.9%. And that is an increase in both areas over the last year. The Healthy People 2020 goal is 82%. So we still have work to do, but we are moving in the right direction. And so congratulations for all of the hard work you're doing in promoting breastfeeding. Yes, in Kentucky, our latest data is the WIC initiation rate is 54%. And statewide from the CDC, our breastfeeding rates are 73.9%. And the Healthy People 2020 goal is 82%. And we have some regions of the state that are above that 73%. I think we have some that are even up to 79%. So we're doing some good work. Also, I really want to recognize we have some local agencies that have just received a national recognition for their work in breastfeeding. The 2019 Kentucky Loving Support Awardees, these are our local agencies that have the breastfeeding peer program. We've got 6 of them that have received this, and this is Bell County Health Department, congratulations. Boyle County Health Department, congratulations. Breathitt County Health Department, congratulations. Cumberland Valley District Health Department, congratulations. Lake Cumberland District Health Department, congrats. And Whitley County Health Department, congratulations. And some of these health departments have just been working with the peer program. You have to have had the peer program at least a year to apply for this award, and you have to be following all of the policies and procedures with the Loving Support Breastfeeding Peer Model. And you also have to do an assessment in your community on breastfeeding. And a number of these awardees have only had the peer program 1 year and have already reached that success. So I'm really proud of these agencies. We thank you for all of your hard work. And I know you work very closely with staff in our office, formerly Britton Bibb and then Marlene Goodlett. And if you have any questions about that, they're always there to help you out. So thank you. This is a national award from USDA. So that's something to really be proud of, the number of agencies that we got recognized this year. I know that I am running out of time. I will tell you that we're also doing some work. Some of you may have heard of CoEffective. It's a group that we've primarily been working with our agencies that have a regional breastfeeding coordinator, but we did conduct some surveys of all of our WIC clinics to get your feedback on how we're doing with breastfeeding. Do you feel like you're getting state support promoting breastfeeding? Where do you feel like you need some additional information? Do you feel like you have a good relationship with your hospitals? And then we surveyed hospitals as well. And so Marlene is collecting that information, and we're going to come up with a plan to increase breastfeeding and help identify those gaps in services and help coordinate and partner. So we're excited about that. Also, we have the opportunity with this project to increase WIC referrals and provide some education to our hospitals about who's eligible for WIC, because we do find there's a little miscommunication about the income guidelines and WIC, and maybe not all the referrals are being made to WIC that could be made to WIC. So that's a great opportunity for us to increase breastfeeding rates as well as referrals and participation in the program. And one last thing, I want to talk about breast pumps. Some of you, well, each agency has recently received a shipment of breast pumps. I wanted to just give a little background on the breast pump because it's a new breast pump that you've received. In the past, you received a hospital grade breast pump, which was the Hygieia Endure, and you received a single user breast pump, which was the Amida Purely Yours. What we did when we went out to bid this time is we said, you know, with those hospital grade breast pumps, they're having to track participants down. When they take the pump back in, they're having to bag it, let it set 3 days in case there's any bugs or anything in that. Then they're having to inventory it in, and it's a lot of additional burden on our clinics. So what we did is we wrote the specs this time for a pump that was still a single user pump, but was a little higher grade and closer to a hospital grade pump. So that all you have to do is issue it and forget about it, other than providing those moms with any support that they need. And so we were trying to reduce that burden on you So you don't have to track the pumps back down. You don't have to clean them. You don't have to hold them in bags to prevent any bugs that may be coming back. And so if you have any questions about the pumps or any pumps that you currently have on hand that you think you might need to get rid of, contact your regional breastfeeding coordinator. If you don't know who that is, you can contact Marlene Goodlett, and she can let you know who that is. We have charged them with working with their region to help each agency identify what pumps they continue to need and what they no longer need. But we really, the main purpose of this new pump is to make it easier for you all to issue pumps and less work. So with that.
Wow. I think we need to have Marlene,
yes,
a permanent part of the
yes,
public health. There's
yes,
so much going on.
Marlene
so
is always full of information.
Yes, Marlene and Nicole will continue to hear from you guys. So
okay.
Thank you.
Thank you.
Okay, so now we are going to talk about public health transformation, and look at my nose. We've got are very pleased to have Scott Lockard, who's in Hindman, Kentucky, I believe, today. So we're going to see if we can cyber move Scott into this. We have talked about public health transformation at every public health nursing webinar this year, but it's always been somebody from the state talking about it. So I asked Scott if he would give us a local health department director take on this. So we're going to see if we can find Scott.
Okay, very good. So I don't know, you may not be able to see me here. I don't know if that's going to work or not. So that's good. I can just talk, and that is always fine. So.
And your slide is up, so they are seeing the slide that you want.
Okay, very good. Since you can't see me, just pull up a picture of Brad Pitt and look at that while I'm doing my presentation. So that'll work. I appreciate the opportunity to talk to our public health nursing group here about public health transformation. I'm sure you've been hearing a lot about this. Public health transformation has been causing a lot of excitement as well as a lot of concern, I think, across the state. And since I have not seen before what you all have seen, heard about public health transformation, I just wanted to start very basic. And I know it looks like they're working with the slide here, and you got it all up now. Great. Public health transformation has come about kind of as a necessity, as we have seen decreasing funding for public health and increasing expenses, most notably the concerns about the pension costs. Many of our health departments have had to look at what they're going to do to manage this situation and how we're going to work together to make sure that every community is afforded a basic level of core public health services. Because our health departments all across the state, we are in very different circumstances. We have different funding available to us afforded by our local tax bases. We have some counties that have very little funding and some counties that have adequate funding to meet their public health needs in their community. So the core public health, with the focus of foundational public health, we have these 5 key focus areas. And these mostly are statutorily defined, regulatory defined through the Kentucky Revised Statutes, the Kentucky Administrative Regulations, define what we do for our communities. So with that focus on population health, what we're doing in population health, we've all seen the pyramid of how for so long we focused on individual counseling, and while that is great for that individual, that has the least impact on the community. So how do we do more population health initiatives there, like getting trails in our community and opportunities for individuals to access healthy fruits and vegetables at farmers markets. Enforcements of regulations. Our environmental division does a great job of this. We go out in our grocery stores, our restaurants, we look at all these different regulations, and we make sure that our food supply is safe, people are handling it in a safe manner, and things of that nature. So a lot of when a lot of the general public thinks about public health, they think about our environmental services and those regulations that we enforce. Then emergency preparedness and response. And this shift came about post 9/11 when we saw that public health, a big part of what we do is related to making sure our communities are prepared for whatever emergency hits. Be it a natural disaster like the tornadoes that struck Morgan County here a few years ago, flooding, which has, hit many different parts of our state, or, a bioterrorism event. So how do we form these partnerships and work with our local emergency management, law enforcement, and so on to make sure that we are responding in the best way possible. And then communicable disease control. We have seen, a lot of this here lately with the hepatitis A response and how we as in public health have mobilized, worked with our partners at the state, and all of us realizing we are one team, and how do we work together out here to control the spread of hepatitis A, mass vaccinations in our jails and our drug rehab centers, and just trying to get the public in general vaccinated. So that and tuberculosis and all these other fun things that we get to work with all the time. And then, our administrative and organizational infrastructure, somebody's got to pay the light bill. Somebody's got to make sure that you have needles ordered and doing these different things. So how do you have it? Administration. All this is driven by our community health assessment and the importance of that CHA and working with our partners to see what are the needs in our communities, and then developing those community health improvement plans so that all partners around the table are addressing those needs in the best way and most efficient way possible. Part of these other core public health functions, we just heard a great presentation on WIC here and the importance of WIC and getting this supplemental nutrition to our women, infants, and children out here. And then the HANDS program, home visitation. How do we support families to build healthy, safe environments for the optimal growth and development of their children? So HANDS home visitation, it's hard to believe that HANDS has been around now 20 years because I remember being a part of it when it first started, and we thought, wow, that's forever in the future. And now looking back, and how do we make sure HANDS is still very viable and ready for the next 20 years? And then a part of public health that has really risen dramatically here in the past few years is our harm reduction and substance use disorder services. If you had told me when I first started working in health departments that we one day would be doing needle exchanges, I would have laughed and thought, you are very out there. But now we have over 60 approved harm reduction needle exchange programs here in Kentucky River District. We now have total coverage. We have just received approval for 2 more counties in my 7-county district. So we will now, effective October 1st, be serving all 7 counties, and we have exchanged our 300,000th syringe here in Kentucky River District. So it's just milestones that's hard for me to fathom. And so many of us around the state are doing such good work through the partnership with the Department of Public Health. We have the 5 mobile units now that are being deployed. So again, something we would never dreamed about here just a few years ago, we're so actively involved in. And then you get into what we call our green box services, is what a lot of people have referred to these. These are our local public health priorities. Again, if we have enough funding to meet all of our core public health focuses here, how do we then use our community health assessments to see what else needs to be done in our communities, and how do we use that funding and our assessments then to come up with evidence-based interventions through our local public health priorities. For some of our health departments that are still engaged in home health, this is one of those services, school health, other various different things there that are those local public health priorities. So again, just that overview of public health transformation. What has been happening out here, we have seen with many of the local health departments that we are making some of us more rapid movements towards this model than others. And again, it's primarily driven by funding. In health departments where we have very scarce resources, we're having to consolidate services. We are having to look at, how we do business. Others, I know there's health departments that have completely, this year, they're getting out of women's health services altogether, which, is just a thing that we would have never dreamed of a few years ago. We see other health departments that are scaling back on family planning services. Like we're doing here in Kentucky River District. We're really prioritizing our teenagers and looking at those young ladies that we don't want to become young teen moms, and how do we focus those services, and individuals who have health insurance, how are we linking them to providers in our communities? And again, this is very much contingent upon what's available in our community. We have some communities that are saturated with federally qualified health centers and rural health clinics, and how do we link them to those services there? So if there's no longer that need for us in the local health department to be a primary clinic provider, that we're really scaling back those services and focusing our scarce resources on these other areas that the other parts of our public health system cannot provide these services that are truly our domain. A lot of this has, again, been driven by finances, and I'm just going to touch briefly here on the special session and House Bill 1 that came out of that, because I know this is a big concern to a lot of our existing staff. The special session, our pension issue is the biggest threat to our financial security of our local health departments. And we saw that pension contribution rate go from 49% to 84% this year, July 1st. Now, the special session, what it did was that when that bill passed, it rolled back our pension contribution rate from 84% back down to 49%. This was a huge cost savings to our local health departments. And so this additional reprieve for this additional year was very important to us as we make this transition to our public health transformation model. What the House Bill 1 also did was it afforded options to local health departments. Local health departments, mental health agencies, rape crisis centers, domestic violence shelters, what are called the quasi-governmental entities. For the local health departments now, for the first time in our existence, we have the option to opt out of participating in the Kentucky retirement system. So finances, again, and how this impacts, this is going to really have a great influence on how quickly we shift to this public health transformation model. The options were afforded in House Bill 1 is a hard freeze, which is of most concern, obviously, to all of our employees, because it would freeze all of our retirement participation effective July 1st, 2020. So all Tier 1, Tier 2, and Tier 3 employees would then no longer participate in the Kentucky retirement system post that date if they were an employee of a local health department that opted out of the system. Then there is what's called a soft freeze. The soft freeze would protect our Tier 1s and Tier 2 employees, allow them to remain in the system until they retire, but prevent the health department from bringing anyone new into the retirement system post July 1st, again, 2020. And then the other option is that we continue to participate in the retirement system and pay whatever the contribution rate is, which is the exact same situation we're in right now. So these are all options that must be chosen by a local board of health. And so the local health department director and will be presenting these options to their boards, and we will be discussing them and choosing what is best for each of our local health departments. The time frames for these choices, we must submit a request to the Kentucky retirement system to calculate how much each of these options will cost us by December 31st of this year, 2019. Then we can not elect any option until April 1st of 2020, and we have 30 days basically until May 1st of 2020 to elect which option we're going to do. If the local board of health so chooses to pass a resolution to opt out of the system and choose a hard freeze via installment or lump sum, soft freeze via installment or lump sum, or if they're going to stay in the system, they do not have to do anything to send to the retirement system. And then July 1st, 2020 will be the date that this takes effect. The affordability of each of these options is very much in question. And as the preliminary numbers that we've been given is that most of these choices are not affordable for most of our health departments. And so we still have further opportunities that we will be going back to the legislature here in January when the session convenes again, and trying to get further relief, try to get some revenue producing options on the table to help us to pay the full freight for our health departments. I've heard none of my colleagues express a desire to leave the system. We all are very much on board with, we want to safeguard our tier 1 and tier 2 employees and choose those best options. Now, what health departments have been forced to do is to try to come up with the most creative strategies they can to reduce their pension liability and to continue to provide the much needed services that our communities need. And so hence we see the increase in the use of staffing companies and other different options again, the choices that we're faced with here as a director of an agency is, how do we continue to provide the much needed services in our community? How do we honor the commitment that we have to our most valuable resource, which are our employees, especially those that have been working with us for long term? And how do we continue to be a financially viable agency? So public health transformation, as we're moving forward with this, I think you'll see health departments that are continuing to focus on these core areas. I just heard the other day that another agency may have elected to get out of home health altogether. When we're looking at these other services, home health, school health, if we have a model that the program is self-sustainable in some of our health departments, and that's why you can't just judge and say, well, you need to do this, you need to do that. In some of our health departments, some of these other programs like school health and home health are not only making a surplus, but they are also absorbing a big part of our administrative indirect expenses, which will not go away if we lose that program. So it doesn't make sense to shut them down. So again, we have to make these choices locally and decide what is best while continuing to all work together to make sure that the Commonwealth is protected with core public health services, regardless if you're in a county with a huge tax base or a small tax base. Every citizen of the Commonwealth of Kentucky deserves to be able to expect a basic level of service from their local health department and know we're all working together to promote the common good. So that is the brief update from beautiful downtown Hyden, Kentucky and Leslie County today. So any questions that you have for me?
I can't see. Thank you, Scott. Can you see that? Does it work?
I can see that. Thank you very much, Scotty.
Finally connected with Hyman, so there's Scott Lockard. Thank you, Scott. Do we have questions that have come in for Scott, Sharon? And while Sharon is looking, I do apologize. We did not check the WIC questions, so we're going to send those WIC questions to Nicole, and we will be sending to the nurse leaders her answers to those questions. I apologize. One thing I did want to point out is with part of public health transformation, Dr. Howard had different health department directors put together some white papers on WIC and on HANS, on communicable diseases. What was the fourth one, Scott? Finance? Maybe. Anyway, so local health department directors have written these white papers. They've met with staff. I was in the meeting with WIC. I think we're having some really good conversations of challenges that local health departments have and ways that we can change those. I'll get glasses on.
And this is, Connie, if I can interrupt just a second here. Dr. Howard, this is being his last week with us here at the Department of Public Health. I think we all owe a huge thank you to the leadership that Dr. Howard has provided us. He has worked with a group of directors. He has been the most accessible of any commissioner I've ever had the privilege of working with, and has allowed us to have input, and we wish him well as he goes on to his White House fellowship. And I think it's reassuring to all of us to know that the leadership that remains is committed to public health transformation, and we're continuing to work together to work on legislation that will enshrine this in law and continue down this path that we've all worked together to head down. So a big shout out to him. Thank you all.
I heard him say the other day, we were at a point in December where we didn't know what we were going to do. And now 8 months later, we're already working on writing the legislation and have met with legislators, which will help us to make this come to life. So, and that wouldn't have happened without the health department directors and staff making this all happen. I did just find out you're talking about syringe exchange programs. I wanted to know where we were in the state of Kentucky with the number of syringe exchange programs we had versus other states. And right now, the leading state in the nation with syringe exchange programs is New Mexico. They have 64. They've been doing this since the mid-90s. Kentucky now has 63 active syringe service programs in 55 counties, and we have 4 programs waiting to go live. So when those 4 programs go live, Kentucky will have more syringe service programs in the country. And that is the hard work of all the local health departments, working with those boards of health and those city councils and those fiscal courts, and a huge lift, a lot of heavy lifting by a lot of people. Van Ingram, who's our partner at the Justice Cabinet. So we are really affecting a lot of lives with the work that's done on the ground, and we're appreciative of that. Do we have any questions for Scott?
Mm-hmm.
No questions for Scott. Okay.
Thank you.
Thank you so much for taking the time to do this. I know this really kind of put a kink in your day, but I really appreciate you being here. Thanks. Okay, our next speaker is Stephanie Lotkus from the North Central Kentucky District Health Department. And at our Nursing Executive Committee meeting, the council the other day, we were talking about different programs, and she brought this program up called Stop the Bleed Initiative, which I was not familiar with. And so I asked her if she would be willing to come and present on this. It's an option that their community found helpful, and I'm anxious to learn about it. So Stephanie, thank you for agreeing to come.
Absolutely, thank you.
Yeah, there I am.
There you are.
There you go.
All right, so as Dr. White said, my name is Stephanie Lockett, and I am the Director of Nursing for North Central District Health Department. And what we're going to talk about today is the Stop the Bleed initiative. And the way that I initially got involved with this was actually through my children's school. I'm the treasurer of the Education Foundation there, and we received a presentation from our emergency management staff in Henry County, just talking about what the program was and how we could possibly get involved through the Education Foundation. So that's how I learned about it at first, and I'm excited to share this information with everyone. So what is Stop the Bleed? Stop the Bleed is actually a program that is a collaboration between several different government groups and other agencies. The Hartford Consensus, the American College of Surgeons Committee on Trauma, the Committee on Tactical Combat Casualty Care, the Department of Homeland Security, and then the National Association of Emergency Medical Technicians. So a big group of people that got together to try to work on this. And the goal of Stop the Bleed is just to be a national awareness campaign, and it encourages bystanders to be trained, equipped, and empowered to respond to trauma situations where bleeding is involved. Essentially, as we are seeing more of these trauma type situations, we know that early intervention will save lives. So if we can stop the bleed, essentially, then we can save lives of people in these situations. Where did this initiative begin? In December of 2012, Sandy Hook Elementary School, most of us remember that incident. 20 children and 6 school staff were shot by one individual. And at that point, following other mass shootings, things that many of us in the state are familiar with, unfortunately, the American College of Surgeons convened and created a committee to actually create a national policy to figure out ways to enhance the rate of survival in these types of incidents. And then in 2015, the White House actually was involved and issued a call to action and this national awareness campaign that we now have around Stop the Bleed. So why is this important? Events of violence have become an unfortunate reality in society today. I believe 2 weeks ago we had incidents in both El Paso and Dayton. An average of 100 Americans per year die from gun violence. and and Americans are 25% more likely to die from gun violence than residents of peer nations. So we're not doing great with that statistic. But I don't want you to think that Stop the Bleed is just about gun violence. It's also about car accidents, accidents at a workplace. There's actually a video that shows a child tripping and falling into a trophy case at school, and their arm has a large laceration. And so Stop the Bleed is for all of those things, but it just has come about because of these random acts of violence or just acts of violence in general that we're seeing. This is important because trauma is the leading cause of death in the United States for persons under 45 years of age, and overall the 4th leading cause of death. Approximately 40% of trauma deaths worldwide could have been prevented if there were proper bleeding control at the time of the incident. Therefore, hemorrhage becomes the most preventable cause of death in trauma situations. So since 2015, as I said, the White House really kicked off this initiative in 2015. We've had nearly 40,000 instructors trained for Stop the Bleed. I'm proud to say that I'm an instructor and my husband is in the process of getting trained. Training is available in 90 countries and in all 50 states, which is very exciting. And more than 5,000 individuals have been trained in Stop the Bleed techniques. And this is everything from healthcare providers to lay people, teachers, even students in some high schools have been trained. So when we say Stop the Bleed, this is a kit. And the kits just like this is what you'll find in a lot of public places or schools. This is what you can purchase. And the goal is eventually to have these kits accessible at schools, entertainment venues, basically anywhere where there's a potential for trauma and also where there may be large groups of people together. Inside those kits, each wall mounting contains 5 small kits. So just little red pouches like you see in the photo. These contain a CAT tourniquet or a combat tourniquet, gauze, gloves, scissors, a marker to identify when you put the tourniquet on, because once you put it on, it doesn't come off till a surgeon takes it off. And then trauma blankets. And these kits can be refilled, but they're also small and portable. So if an incident occurs, say in a classroom at a school, you can go get one of these small kits out of the box and then take it to the classroom without having to carry the whole bulky package. Training for Stop the Bleed is a really easy course. It's an interesting course, I think. Typically 4 hours. There's not a refresher involved. Training kits are available, so you actually get to work with the tourniquets. And becoming an instructor is pretty easy. Once you take the course, you can go online, become an instructor, and get involved with local organizations like emergency management or EMS that are training for it. So this is just one of the graphics that are used and sometimes displayed with the Stop the Bleed kits, just to give you an idea, applying a dressing or applying a tourniquet. I first became an EMT in the year 2000, and we were taught that tourniquets were the worst thing ever. You tourniqueted something, that was it. It was falling off. Now we're taught that these tourniquets, when applied correctly and removed correctly, can actually save lives. So at North Central District Health Department, we decided we wanted to get involved with this initiative. So last year, we partnered with KDPH through the CHAT program, and also with our local schools and emergency management officials. And our department was able to purchase and place Stop the Bleed kits in each of our public middle and high schools in the district. So we purchased 20 kits and 8 training kits. We also, because of our involvement, motivated another group, and now in Henry County specifically, there's a kit in every single school. So I think that is a huge accomplishment, and it makes me feel safer with my children in school there for sure. When we bought the kits, we had an event at the district office to distribute the kits to each school system. The commissioner came and spoke, and we had a lot of great folks there from the community. Our emergency management gave a presentation. And this is actually one of our, or 2 of our EMS folks from 2 of our counties working together to demonstrate how the tourniquet works. And then since distribution, as I said, I'm an instructor for Stop the Bleed, and so our department has assisted with training for the use of these kits throughout our counties. So what can we do? What can you do in your health departments to get involved? Work with your community partners to see about getting these kits in your areas for sure. Become instructors or even help facilitate classes. Maybe you have somebody in your community that's already an instructor, but they don't have anywhere to hold a class. So maybe your health department can contribute in that way. Also, get involved with community education and outreach efforts. We want everyone to know how to use one of these kits. It's kind of like the AED. You want to know how to use it if it's accessible to you. So we want people to know how to use these and to know that they can use them. So that's my presentation. Definitely, I think Stop the Bleed is a great initiative. I think we're going to save lives with it. At this time, if there's any questions.
Does anyone else have them besides the schools? Have factories or government buildings got them now?
So at this point, we only have them in the school systems in our district, but I know that some of the county judges have expressed interest in having them, even just, around the courthouse or places that there could be incidents. Additionally, the kits are somewhat portable. So I know that they took some of the kits from the school system to the county fair when that was recently held.
Field trips, do they take them on field
They
trips?
can. Eventually, we'd like to have one in every classroom, but I think having one in every school is a big accomplishment for a year.
Yeah.
So we're good?
Nothing so far.
All right, well, thanks for letting me speak to you guys today.
Okay, well, thank you very much. I appreciate that. That was a good presentation. I knew nothing about this, and I think this is a pretty awesome way for us to get involved in our community. Okay, so our next presenter is going to be Brian Hellman, and he's a community organizer for KPAP, the Kentucky Prescription Assistance Program. His division director, Devin McFadden, and I always talk about how this is one of the best kept secrets of the whole state of Kentucky public health, because this is another program that certainly affects the lives of a lot of our Kentuckians. And Brian has the distinction of kind of being the lead on this, where he started this, and Brian, you can tell them what year. I'm sure you're probably going to go over that, of when this program started and how Kentucky took that lead that you had and have made it into a statewide program. The number of volunteers across the state is incredible. The amounts of money of medications as dollars that have been saved for Kentuckians continues to just absolutely blow me away. And I just don't think we have talked about it as much as we need to. So can we see if Brian is showing up? You did it.
Thank you so much. My name is Bryant Hellman. I'm a community consultant and community organizer for the KPAP, Kentucky Prescription Assistance Program. I actually live and I'm located here in Paducah on the far western side of the state here in Kentucky. KPAP was started after the state legislature passed in 2008, and I co-founded a very small nonprofit here in Paducah with a gentleman out of our homes, and the Kentucky Prescription Assistance Program, along with another program actually in Elizabethtown with Carol Baldwin. The program was modeled on kind of both of the things that we were doing at the same time. There are about 350 different pharmaceutical companies that offer what's called patient assistance programs. Sometimes people call them PAP programs for short. There's also a couple of foundations out there that do things like help with high out-of-pocket copays for people with chronic diseases. Sometimes when you're watching television, you'll see that commercial with AstraZeneca. They'll say maybe AstraZeneca can help if you're not able to afford your medicine. But a lot of folks don't know how to access these programs. We know that a person with chronic disease in our state, I believe the last numbers we looked at, the average was almost over 16 medications that they stay on consistently. And so if, for instance, if you had 16 medications that you were staying on to survive and to be healthy, good chance that you might have 16 different companies or 12 different companies that manufacture those medications. There is no golden rule or guidelines for these pharmaceutical companies to do the programs or to build foundations. They do it on their own free accord, and that's a wonderful thing. The only problem is at times, they all have different rules, different qualifications, things that apply to them. So what we end up happening is someone that has maybe 12 or 15 medications, 12 or 15 different sets of rules. One program may help you if you make under 250% of the federal poverty guideline. and another program may help you if you make 400%. So some people qualify for some medicines, and then they don't qualify for others. It really just depends on the individual, the circumstances. It depends on what those foundations are willing to do to offer them assistance, and it depends on their situation with their insurance and things like that. One of the things that we try to do is we partner with basically anyone in the Commonwealth that wants to partner with this program. We partner with faith-based groups across the Commonwealth. We partner with nonprofit organizations, social service organizations. We partner with hospitals. We have a pretty diverse partnership of over 450 now trained advocates that do this program every day. And so what we see with that is we're able to help individuals, number one, that don't have insurance coverage at all. We're almost always able to help them. We're also able to help people that are, they have insurance, but maybe a medication has been denied. So maybe they're getting a majority of their medicines, but that one high-cost medicine they're still not able to obtain. We're usually able to help them get that medication. And if we're not able to get it free, a lot of times we're able to get it at a reduced cost price to kind of lift that burden from them. One of the favorite things that I get kind of excited about and talking about with this is we're also able to help a majority of patients that are in what's called the Medicare Part D donut hole. I'm sure lots of people have heard that. It's the catastrophic coverage with their Part D benefit with Medicare. And this time of year right now, and especially getting into the fall, we'll start seeing a lot of senior citizens in Kentucky that find themselves in that Medicare Part D donut hole. So, January and February and March, they're going along and they're paying a small copay at the pharmacy to get their insulin, to get their high blood pressure medication. And then all of a sudden they come in one day and, it's a $4,000 or $5,000 or $1,000 charge for their medicine. And on a fixed income, it's, basically impossible for them to get access to it. So about 4 years ago, really the three major pharmaceutical companies that manufacture insulin started opening up their foundation to patients that have Medicare. So people that are disabled and senior citizens are able to get their insulin through patient assistance programs. There's a lot of different qualifications they have to do to get those. There's a lot of roadblocks that come up. Nothing is simple really when it comes to these things. So what we're trying to do is take all of this information and centrally locate it in one place so anyone can become an advocate for people in their community. We don't have dollars attached with the program that goes in and pays people in counties. It's a volunteer process to join and partner, and we're always looking for people in counties to house this program and to use it. One of the things that we do provide free, however, is we provide free on-site training. We have 3 community organizers. I'm one of them, and I cover Western Kentucky. I go almost as far east as Somerset, but more on the south part of the state. We have Carol Baldwin, who is an organizer for the central part of Kentucky, and we also have Deanna Jesse, who is a organizer in the eastern part of Kentucky. So one of us, depending on where you live in the area, we would come to actually where you are. So your staff, your volunteers would not have to drive anywhere. We'll actually come on site and schedule a training with you one-on-one. We also provide internet training through Drug Assistant, which is a software application that we use to help manage this program. We do live web trainings with them every month for advocates if they want follow-up or if they feel more comfortable with them. We also offer that for free as well. We do also provide free IT support and free ongoing support. So when things happen, I know computers work perfectly all the time, but when they don't, you can give us a call, and we're there to help with. We also help train people in the different processes for patient assistance programs. So for an example, if someone has a medication that's a name brand drug and it might be pretty expensive, and they get the good news that it becomes a generic, a lot of times those foundations will drop that name brand drug for free. And then all of a sudden they have to pay out of pocket for that generic. And we also utilize a special program called RX Outreach, with our advocates, and it's not anything that we charge or that Kentucky charges or that our advocates charge, but this foundation does charge a very small fee for either 3 months or 6 months worth of the medications. Usually it's around $20, $15. It depends on the medicine that we're looking at for that patient and what the rules are. As a golden rule, about 70% of the programs out there have a 250% federal poverty guideline for income qualifications, and that's very high compared to a lot of programs out there that are available for people. I talk to people all the time where even when they hear of the program, they don't reach out at first because maybe they've been denied for the SNAP program, or they've been denied for other programs that are out there to help because they're told they make too much money. We have several programs out there from some big pharmaceutical manufacturers, Merck, for instance, which has just a ton of drugs on their patient assistance program. Their income qualifications are 400%. So to put that in perspective, if you're looking at a chart by your desk, a family of four, I don't have the number in front of me, but that's close to $75,000 a year in income that they could make and then still get this medicine for free. If you partner with the program, you don't have to warehouse medicines. You're also free to do that if you have a pharmacy at your hospital. Basically what happens is we try to make this as easy as possible for the prescribers that these patients see. We take all of the forms, income documentation, and everything from the patient and try to put it together nice and neat in a folder so their prescriber can sign them and then either fax them in or mail them into the company. It's usually, and again, it depends on the foundation. Everything's different, but it takes anywhere between 2 weeks and 4 weeks for them to receive their medications. Most of those medications are just shipped directly to their home, unless it's a medication that foundation requires for it to go to their prescriber's office. We see that with insulin and other medicines like that sometimes that are required to go to the prescriber's office, and then the patient comes and picks them up. Total in our software program, we have a little over 5,000 prescription medicines that are free, and we have about 350 prescription medicines that are what's called, again, reduced cost. There is a small payment for those medications, but it's certainly a lot cheaper and a better alternative than what they would have with maybe their current insurance or no insurance and coverage at all. One of the things that we try to do as well is we help people that kind of navigate the process. Number one, I see it every single week when I work with patients. They'll come in with that big purse and all those medicine bottles, and sometimes they're taking medicines that they shouldn't be taking anymore because it's kind of confusing keeping all that together. So our advocates are helping them one by one go through their medication list with the frequency and the dosage, checking with their prescribers, making sure that they're still supposed to take those medicines, making sure it's the right medicine. We also provide information through our software through the National Institutes for Health, because one phrase we heard constantly is, I'm taking this medicine. I see 3 different doctors for my chronic disease. I'm always in appointments, and I just can't remember why they told me to take it. I know I'm supposed to, but I don't know why. And so we're able to actually instantly print from the National Institutes for Health and give that patient some more clarification and answers on why they're taking their medicine. This year so far, I did pull some reports this morning to kind of see where we're at with numbers. Numbers are important with the program. So far this year, we've helped find 11,564 prescription medicines, and I believe those are all medicines that would not have been filled if they wouldn't have reached out to a Kentucky Prescription Assistance partner and if a community stakeholder wouldn't have partnered with this program at all. That's over 2,809 patients so far this year that have received the service and been successful in finding medications. And the average wholesale price for all of those medications is over $27.8 million just this year. Since inception, since 2008, we really started, October 2008 is when the program started. In early 2009 is when we started having our first partnerships in the state. And we've been able to find over 526,872 prescriptions. That's as of 7 o'clock this morning. We've helped almost 60,000 patients so far find free prescription medicines, and we're at a little over $783 million since 2009 being active out in the communities and partnering with diverse groups to get this done. I set a timer because I get excited and want to go through this a lot. I know I'm running short. I want to give everybody, though, our 800 number if you know patients out there that need help. And also, if you are someone that says, hey, this sounds like something that our facility would like to have, or maybe you belong to a church that wants to, expand their ministry, I'm all ears. But you can give us a call at 1-800-633-8100, and someone will be able to assist you. And for number one, to be able to find those patients help, and number two, hopefully there's people out there listening today that might want to partner and do this program with us.
Now, you do have 5 more minutes, so would you?
Oh, I do. Okay, well.
You do. You repeat that phone number again.
Yes, it is 1-800-633-8100, and that's our Healthcare Access Branch hotline number. So if someone is a patient somewhere and they say, I have insulin, I have high blood pressure medicine, I just can't afford this. Maybe it's a problem with Medicare, my insurance, or I have no insurance, whatever the situation is. They can call this number, and there will be someone that helps them find the closest Kentucky Prescription Assistance Program near them. If there's not one near them, we have partners here in Paducah with Heart USA and other partnerships in the state where they'll say, we'll basically take anyone in the state of Kentucky that needs help. We can do it over the phone, and we can also mail them or fax them the applications and things that they need. So what basically happens, since I have a little bit more time, I can kind of, and maybe you can just wave at me when I get close.
Okay.
It's very hard to navigate all these programs.
4 minutes.
Okay. And so what our software actually does is it allows patient advocates that we train. Training usually takes about 2 to 3 hours. Once that advocate's trained, they'll have the access to the software, and they'll have the ability to put in the basic demographics for this patient. Once they do that, they can search over 5,000 medications. They can look and see if that patient qualifies. And each of these patient assistant programs are anywhere between 1 to 6 pages long, and it's a lot of information to fill out. This software will actually auto-populate all of those pages of information with the patient's demographics. It will auto-populate all of the prescriber's information, taking the prescriber time. And what basically happens then is we train the advocates to include the patient's income on each form and instructions with the prescriber and the patient on how to access the program. So when they leave a KPAP office or they receive it through the mail from a provider, they're able to get their, excuse me, I have feedback going on. They're able then to get the medication sent to them. We do have counties right now where we don't have providers. Things change, nonprofits open and they close, budgets change. And so we're always looking for new partnerships out there. Your health department can provide this. Your hospital, again, can provide this. And we're happy to go talk about those things. And we're happy to train any of your staff and your volunteers from everything from HIPAA to how patient assistance programs work to how the software works itself. This really takes about 70 to 80% of the time away that it usually takes if you were to try to attempt to register people, by using Google and different websites and filling out all of these forms for them. We do see a lot of patients in rural areas that don't have internet connection. So AstraZeneca may be able to help on the commercial, but a lot of seniors in rural areas are not pulling out their laptop and getting online with their Wi-Fi and having a printer at home that's expensive and printing out just all of these pages of information, going through 12-point font size forms, being able to see it, read it, and figure it all out, especially while they're going through, maybe first ever being diagnosed with a chronic disease, which we see as, something that people come in and maybe they just don't do things like they normally would because they're going through so much. And just having that extra person there going with them through their medications, helping them figure it out, I think is almost just as important as actually getting the medications themselves sometimes for people. We do have a lot of roadblocks and things that come up with this program that we try to train advocates on how to navigate. Sometimes patients will have to have a LIS denial letter. They'll have to actually apply for the low-income subsidy for Social Security. So we teach them how to work with their local Social Security office to get those things. And again, it's something that I think a lot of people, when they're left on their own to try to figure out, I get very confused about it, and I do it every day. So if I was sick and had something else going on and it's something I've never experienced or navigated, I don't think there's any way that I would be able to do it personally. So we do see that a lot, and we work and we try to partner with different groups out there that sometimes they have to have those things. Sometimes they have to have a PA from their physician and insurance company. Sometimes, again, they have to have those denial letters, and so we have to go through just a couple more steps, but we can help them.
Right. Well, I will tell you, when I was in private practice, the number of patients that would take their blood pressure medication 1 month and their heart pill the next month and their thyroid pill the next month because they couldn't afford to buy all three of them in the same month. And so this program is a true lifesaver. And thank you for initiating it back in the day and all your work. I know that Devin had a wonderful visit down there in Paducah with you, and it was great.
Yeah,
so,
yeah, and hopefully we can come back again, and we'll have another one. So well, our little site over here has done over $6 million in free medicines for people in our county this year already.
Wow. I wrote down to $27.8 million of medicines this year. I was checking to see if there are questions. I know that Devin and the people in PQI are working on an infographic for this. And that phone number that Brian gave you, that's another best kept secret of our department. It's our 1-800 number, where if people just flat don't know what to do, we have a team of people that answer the phone at that 1-800 number and to help them to navigate programs, because often there are things that we can give them to help them, but they just don't know what they are. And as you said, they're in the throes of a new diagnosis. They don't feel good, they don't understand, and they need somebody to help. A question we got. Okay. Oh, this is the Stop the Bleed comment. Yeah. I'm sorry. This was about Madison County has trained all their fiscal court employees, local churches, and many others from the Stop the Bleed program. So if we don't have any other comments, Rhonda, the branch managers here. Okay. Thank you, Brian. We'll hopefully, I would like to get that infographic, and maybe we can post that on the nursing website along with your presentation. We don't have a PowerPoint, but if we could get that infographic so people could really see the amount of money that Kentuckians have been saved because of the work of 3 very hardworking field staff and just a whole army of volunteers. It's been quite impressive. So thank you very much. We appreciate you coming on today. Yeah. Okay. Thanks so much. So next up, we have Amanda Wilburn. She's an epidemiologist, and she, until 2 weeks ago, she was the viral hepatitis program. She was only staff member, and now we have a whole nother person. But Amanda is going to be telling us about an update on hepatitis C and where we are as a state in our battle against this disease. Thank you, Amanda.
Thank you. Okay, good morning, everyone. Like Dr. White mentioned, my name is Amanda Wilburn. I'm an epidemiologist. I've been with the hepatitis program for about 1.5 years and just recently moved into the coordinator role. I'm going to walk through a little bit of the changes that have happened in the program recently and the changes that we have planned, and then share some data with you that we have here at the state. So historically, the program, it has a pretty short history, and in that time, it's been funded by CDC's Division of Viral Hepatitis for prevention and surveillance activities, and that funding only allowed for up to 1.8 FTE. So we've, as Dr. White mentioned, we've never had more than, we've never had 2 full-time people dedicated to the program. But the good news is we have a new plan And it looks like this. This is what we think that we need at minimum to face the burden of disease that we have for Hep C in Kentucky. So we want to add someone dedicated to Hep B prevention specifically. And then we want to have, zooming in on me. We want to have someone to look at our laboratory data, our perinatal hepatitis C, an epidemiologist on staff to work on special projects. And then we really want to ramp up our linkage to care efforts and our education and TA capacity. The good news is we have some funding secured for several of these positions. We were funded through the ELC grant to get a perinatal Hep C person. We're working with the University of Kentucky to support someone to come on and help with our ELR data. We have someone in place already. That's the new staff that Dr. White mentioned for special projects. And I'll talk about her first project a little later. And then we're working still to fund some of the other positions, but this is where we're headed. So shifting to the data a little bit, as most of you probably know, prevalence estimates for hepatitis C are notoriously difficult to come by. It's a difficult population to screen, but at least the new population with Hep C. And this isn't something that's unique to Kentucky. Other states have difficulty coming up with their prevalence estimates, and there's difficulty at the national level as well. But in 2018, data was released in partnership with Emory and CDC on prevalence. They estimated 2.3 million Americans currently living with chronic Hep C infection, and then estimated 43,000 in Kentucky. And I will say that every national and regional meeting that I've been to since these estimates were released, there's consensus that this still feels like an underestimate. You probably know it better than anyone because you're seeing it on a daily basis. There was talk of working to revise these estimates, but we haven't had an update recently. So I'll shift to what we have available here at DPH as far as data. We have our acute cases that you guys investigate and report to us. We have our perinatal Hep C cases, and then we have our new electronic laboratory reporting data that we receive. So I'm going to talk about each of those very briefly. So these are our acute confirmed cases of hepatitis C from 2005 through 2016 for Kentucky compared to the national rate. Probably not surprisingly, we have always had a much higher rate of acute cases in Kentucky. I will point out on the next slide that some of these states that passed us most recently, West Virginia, Tennessee, and Massachusetts, it's difficult to say for sure if they really do have a higher incidence than Kentucky or if they have developed slightly more robust surveillance systems than we have. We'll just have to catch up to them, but I know that in each of these states they have pretty sophisticated surveillance systems. So that could be an artifact of that, or it could be a true reflection of increased burden. But from 2008 to 2014, Kentucky was in that top spot for hepatitis C. And as many of you probably know, we also pop in and out of the top spot for Hep B as well. So here are our case counts and then our rates of confirmed and probable cases of acute Hep C infection from 2013 to 2018. I want to talk here about the case definition change in 2016. You know, Kentucky only reports around 100 to 150 of acute Hep C cases, confirmed cases each year. We all know that that is an underestimate of new infections. And that's largely due to the specificity of the case definition. It's very strict. A lot of you do these investigations, so you know that. It requires symptoms characteristic of hepatitis. Certain lab results have to be in place, and then it has to have that positive confirmatory RNA test. So it's difficult to capture all of those things at once with this population. I want to note that the case definition was revised and approved in June at CSTE this year. So that's going to change again. I don't have a date on when that will be in place. But when I do, that's something that I definitely want to pass along to you guys and give you information on how that will change investigation and reporting. It should be a little more sensitive and capture more cases. But working with what we have, we mapped our acute cases of probable and confirmed infection by county from 2017.
And you can see where there are concentration of higher rates of acute hep C. It kind of goes with a lot of our other health outcome maps. But I want to again draw attention to the counties that have 0 acute cases reported, and just again acknowledge that that's likely due to the strict case definition and not that there are no new cases of hepatitis C in these counties. So the other data that I mentioned that we have available is our perinatal hepatitis C data. The department started requesting voluntary reporting of infection in pregnant women and children in 2013, and there was enough reports to amend the reportable disease regulation to make that reporting mandatory in 2015. And so that reg requires reporting of hep C infection in a pregnant woman, an infant or child aged 5 years or less, and newborns born to hepatitis C positive mothers at the time of delivery. This is one of the positions that we have on the org chart dedicated just to this, and we hope to bring them on very soon. And another thing that's happening here is we're building a perinatal hepatitis C page in NEDS. It's in the staging environment right now, and it's built after the perinatal hep B template, but we will definitely communicate when that's available for use. With that reporting that started being mandatory in 2015, there was significant number of reports that came in that justified a House bill being passed last year in April, and that became effective in July, that requires mandatory screening of all pregnant women for hepatitis C. And as far, unless something's changed in the last couple of weeks that I haven't heard, Kentucky's still the only state that has that requirement. So if you look at our reporting of perinatal hep C, the red bar represents the number of cases that are reported to the program through the EPID 394 that many of you submit for us. And then the green bar represents the number of cases that are designated on the birth certificate as a hep C positive mother. So you can see there's still a gap. So we here have a lot of work to do on providing support for reporting. And this just represents data from the birth certificate. So these are the number of cases. The green bar represents the number of women with reported hep C on the birth certificate. And then the trend line is the rate per 1,000 live births. So you see this got up to nearly 24 per 1,000 live births. And then if these are the cases that were reported to us by county, again, the concentration is in Eastern Kentucky and in our Appalachian counties, with some of the counties reaching close to 70, 72 per 100,000 live births. This is some data that we have that I felt to mention earlier when I was talking about what we have available. We've had the opportunity to work with our Department for Medicaid Services and increase our partnership there. And one of the things that has come from that is some data around hepatitis C. So this is data for 2017 and 2018. 2017 is green, 2018 is red. The first section represents recipients screened. So these are enrollees over 18 who received an antibody or an RNA test during the calendar year. So you can see those numbers are pretty high. And then the next section are those who received a chronic hep C diagnosis. So these were people who had a claim with a diagnosis code for hep C without a subsequent DAA claim for treatment. And then if you look at the treated category, I think this is the most interesting. Even though there were over 20,000 with the chronic hep C diagnosis, in 2017 only 499 were treated. At the end of 2017 in the fall, that's when fee-for-service liberalized the Medicaid requirements, and it became allowable to be reimbursed even if you didn't have to assess sobriety or fibrosis stage. And then the prescriber requirements loosened as well. So primary care began being able to prescribe in consultation with a specialist. So that happened end of 2017, early 2018. So you can see in 2018 that number quadrupled. In 2017, those 500 people cost $75 million to treat. But the good news is, with the lowering cost of the medications, that cost remained the same in 2018, even though the number of those treated increased tremendously. The follow-up testing doesn't quite match the number treated, but it did increase like you would expect. So the next thing that we have available that's relatively new is our electronic laboratory reporting. The reportable disease surveillance regulation was changed again in October of 2016 to require that all Hep C lab test results be reported, whether they're positive or negative. And so this is for antibody or RNA. This is something that Kentucky's lucky to have. A lot of states do not have this. And I just want to clarify, this does not mean that lab results have to be faxed in. That's an important distinction. This is reported through the Kentucky Health Information Exchange electronically. We've had some labs that have been faxing in all of their lab reports, and that's not required. It's just required that they be linked to KHI and flow through electronically. And then what that does is that flows through into NEDS, and we're able to use it there. So this offers a lot of opportunities to us in surveillance that we haven't had. There's a test conversion piece of the case definition that will help us identify additional acute cases that won't require all of the other components. We'll be able to identify gaps in confirmation testing. We'll be able to come up with our own prevalence estimate at the state level. We'll be able to make a cascade of cure that I'm going to talk about more in a second. And then we'll be able to look at our reinfection rates. There are some limitations, even though this came on at the end of 2016, not all labs onboarded at once. There weren't strict enforcement of timelines for them to be connected. And then also in the process, KHI has recently switched vendors. So there was a silent period during which time electronic messages were not flowing through at all. So right now, those are in the process of being batched back in and making the surveillance piece whole on that. As you can imagine, there are a lot of hepatitis B and hepatitis C tests in Kentucky every single day, so there's a volume issue. We don't want to crash NEDS and make it unavailable for all of the other diseases that we need it for. And then just the staff capacity here to analyze the data is a limitation. But for the first time, we looked at what this data looks like. We pulled all of the positive confirmation tests out from 2017 through June of 2019. So this was any unique individual who had a positive RNA result, and looked at it by county. And so this is what that looked like. Statewide, that was 427 per 100,000 people had a positive RNA result. And you can see some of the highest counties crept up to over 2,500 per 100,000. And this is something that if you're interested, I've provided it to a few health departments already, but if you were interested in your county data here and you haven't worked with me yet on getting it, this is something that we could provide. I want to check my time. Okay, 4 minutes. So this is one of the things that I'm most excited about, developing a cascade of cure for hepatitis C in Kentucky. For you who have worked in HIV, it's similar to the cascade of care. But what we're wanting to do with our lab data is pull out those who are diagnosed, who have a positive antibody or RNA test, and then from that look at how many people are confirmed who have a positive RNA, and then how many have cleared. That's the yellow bar in the confirmed bar. They've had a negative RNA after being diagnosed. And then the people who still need an RNA confirmation test, the RNA unknown, 14,000 people. And let me say quickly that this is not real data. This is just an example of what we want to get to. And then from those confirmed RNA positives in the second column, we want to be able to see how many people are cured. So they have had a subsequent RNA negative result. And then how many still need treatment, who are still RNA positive. So then we'll be able to look at those who are subsequently infected, either from that cleared category or from the cured, and see where we need to target our harm reduction efforts to avoid reinfection. I'll skip that. I want to quickly talk about the vulnerability assessment. I know this is a map of Tennessee, but you're all probably familiar with the vulnerability assessment that CDC conducted and published in 2016, highlighting counties that were at risk of an outbreak of HIV or Hep C. It was on the heels of the Scott County, Indiana HIV outbreak, and we had 54 of those 220 counties in Kentucky. So that research was done in 2015, and the data is a little old at this point because they were using data from 2012, 2013, 2014. And we have received funding from the CDC Opioid Crisis Grant to do a jurisdiction level vulnerability assessment. And that's how we were able to hire the new epi in the program. This is her project. And what she is going to do is use newer data that includes some protective indicators that we have in Kentucky that we did not have when this assessment was done. So all our SSPs will be factored in, all of our harm reduction efforts will be factored in, and we think that it will look a little different. And so why I have Tennessee up is they've already done this, and I wanted you to be able to see that the counties who are light gray were identified in the Tennessee assessment only. So those were counties that either the different indicators used, CDC kind of missed, or that the landscape has changed enough that those counties now represent a little bit more of a problem. So that's something that we are going to have complete by November 30th. And I can say that because it's due to CDC then. And we will share that with everyone, and you know, counties, all the counties will be ranked, and it'll give us just one more tool to target our harm reduction efforts. And then the last thing, we're adding questions to the behavioral risk factor surveillance system. It's the first time there have been hepatitis questions on the Kentucky questionnaire. It's a CDC module, so other states may be adding it as well, and we'll have one more way to compare ourselves to other states. So please feel free to contact me if you have any questions or if you have data. I would, you know, being new in the coordinator role, I would love to hear how I can help, how the program can help, and what you think that we can do to help you on your end. I do have a last name. It's amandab.wilburn@ky.gov. Sorry, my email's incorrect, but my spelling is above. So amandab.wilburn@ky.gov if you need anything. Thanks.
While we're waiting for Doug,
Mhm.
he's supposed to be here like now. So since he's not, do you want to go back to your CRA slide?
Oh, sure.
I was going to say if there was any question. Go ahead.
Okay. So while we wait on the next speaker, I'll briefly mention what the CDA Foundation is doing for us. We got a small grant from ASTHO in partnership with Louisville Metro Public Health and Wellness to do some disease burden modeling. And so ASTHO hires CDA Foundation to do that. And what they did is they let us provide input on who we thought would be the subject matter experts for hepatitis C in Kentucky. And they brought that group together to inform the model. And so they had a call and then an in-person meeting. They came here from Colorado, and they took all this data from different people, state health department, local health department, private providers, academic medical centers, and are building out a model for hepatitis C. So this is something that is very useful in places with either kind of limited surveillance capacity or, you know, growing surveillance capacity. But what they're going to provide, and it's almost complete, are a number of viremic infections, new infections, and then a continuum of cure. So it'll be interesting as we move forward with our surveillance to see how what we get matches up to the model. But in the meantime, that'll be something that we can all use, and I'll share with all the local health departments until we get our surveillance all the way ramped up.
Questions?
Say anything. Not you.
Thank you very much. Thank you, Amanda. We just about a month ago had a strategic planning for hepatitis C elimination in the state and pulled in some of the bigger players that are actually treating patients with hepatitis C. We are modeling this after the national hepatitis C elimination plan. We've had the first meeting, 3 different work groups were developed, and so there'll be more to come on this. So Amanda, we meet in December. This group, we have an October public health nursing webinar and one in December. So maybe then you can come and bring the vulnerability work that Claire is doing, because I think that'll be real important for everybody to see. And then you'll also have the CRA work. So that'll be some exciting work we can have in December. So Doug Thurman just texted me he was coming. So he should be here any minute to talk to you about the hepatitis A, just to give you where we are now. I know we've talked about hepatitis A several times in these meetings, but I do think it's important that you know what's going on, where we are now. The numbers are down, as you know, but the numbers are down, but that doesn't mean that we're done. And the last thing we need to do is take our foot off the gas working on this and then have another increase. So we wanted Doug to come and give you that update. So he's here, so I'll introduce Dr. Doug Thurman.
Hey there, how is everybody today? Hope you're enjoying the webinar. So I just wanted to give an update. If you were on the call yesterday for hospital EDs, it's going to be almost all the same slides, so you can zone out for a little bit. Otherwise, if you weren't, then you'll get the update. So just to go back and look at the whole nationwide outbreak, that began clear back in August of 2016 in Michigan. And Michigan's outbreak was mainly centered in Detroit, the city, and it was mostly an urban outbreak. And then after that, San Diego and then Salt Lake City also got involved. Once again, San Diego was completely urban. Salt Lake City was really urban. And so not a lot of spread into rural areas. And then we got our outbreak starting in August of 2017, so about a year after Michigan started. And our previous yearly average for hepatitis A cases was about 20 cases per year. In November of 2017, we identified 27 hepatitis A cases and had genotyped a couple of them that had genotypes similar to that was being seen in California. So we declared the outbreak on November 22nd. And at that point, it was primarily in Louisville, so once again, an urban area, until about March of 2018, and we'll go into this a little more in depth as I go through the slides. But after that, we had really vigorous spread to the rural drug-using populations across the state. So a national picture as of last week, August 9th, the outbreak has now reached 29 states, so more than half the United States. We're probably over 24,000 cases at this point. The official count on the 9th was 23,978, 14,330 hospitalizations that represent 60% of identified cases. There have been 236 deaths, of which Kentucky accounts for about a quarter of those, so we're high on the death count. And only 2 states have declared the outbreak over, and that's California and Utah. Michigan's pretty much at 0 now, but they haven't completely declared it over. So our outbreak statistics in Kentucky as of August 3rd, that's the date of our last report, we have a total of 4,837 cases. That breaks down to only 59 in 2017 total and about 3,500 in 2018 and then about 1,278 so far this year. This week we had a total of 13 cases. We've been up and down for the last several weeks, going anywhere from 6 or 8 cases up to 15, 16, 17, 18. But we've been staying below 20 cases for a couple months now, 20 cases per week. So the number of counties that have cases has increased. We're up to 94% of our counties, or 113 counties, have been affected. They've had at least one hepatitis A case. And hospitalizations are about 48% of our cases, or 2,340 people have been hospitalized in Kentucky due to hepatitis A. Right now, we're at 60 deaths, which is about 1.2% of our number of cases. And I will say that more recently, we've had a couple of deaths that were probably not due to hepatitis A, but we've counted them because hepatitis A was either listed on the death certificate or it was in their diagnosis a few months before they died and was still listed as a contributing cause. So, but clearly on a couple of the last cases, they had all kinds of other things going on and they had probably recovered from hepatitis A, but then died of other causes related to liver malfunction, things like that, dysfunction. Median age, 36 years. The range is from babies up to 88 years old is our oldest case so far. And the genotype testing that we've gotten done, CDC kind of quit testing our stuff after a bunch of other states got involved because they were overwhelmed. But up to that point, most of our cases were genotype 1B, and that's California cluster A. Or all of our cases were genotype 1B, but most of them were California cluster A, but some are Michigan cluster as well. And we've had a bunch of genetic variation here in Kentucky, just things kind of changing over time within our own population. So CDC is actually interested in looking at us because we have a number of different sub-genotypes that are popping up here, but they're all genotype 1B. So looking again, this is consistent over the whole outbreak. It's been amazingly consistent. If we look at the risk factors of those who got risk factor information collected, you'll note at the little footnote at the bottom that about 19% of our cases don't have any risk factor information because they were never interviewed. And so that's a problem, and that's why we had a webinar yesterday that some of you might have been on for hospital EDs to try and encourage a risk factor assessment as soon as you suspect hepatitis A so that we can get that information before the person disappears or is lost to follow-up, because they don't often stay in the hospital. They leave against medical advice. They often give false phone numbers, and so we can't contact them again. So we are missing data on about 20%. But in the 80% that we do have information on, only about 1.5% report homelessness as their only risk factor. About 72% report illicit drug use as their only risk factor. And then if you look at people who have homelessness and illicit drug use together, that's another 7.8%. So if you put that together, illicit drug use is a risk factor in about 80% of those people who report risk factors, and only in about 10% of those people who report risk factors. So it clearly is illicit drug use that's driving this outbreak, and it's not injection drug use, it's any kind of drug use. We have not seen clusters related to any kind of specific groups of drug users, just across the board. People who are using substances illegally are more prone to get the hepatitis A outbreak. We do have about 19% of people who don't report any risk factors. Now, probably a portion of those are people who do have some risk factors, but they didn't report them. They denied drug use or denied homelessness, things like that. So that is probably a little bit high from reality, the 19%. So this is the current epidemic curve, and as you can see, since about June 16th, we've been below 20, and for several weeks before that, except for the week of June 2nd to June 8th, we were below 20 cases a week. But it's really tailing off. You can see there's kind of an initial hump in May and June of 2018, and then a big increase into October, November of 2018, and then we start seeing the decline, thankfully, across the state, and that's been ongoing. It's just knocking out the last bit that's going to be the real important part. So the one thing that I've been stressing is that really Kentucky's a tale of two outbreaks. As I noted before, all the previous outbreaks in the United States were really based in urban areas, and that's the way it started in Kentucky. The first cases were at the very end of August in 2017 in Louisville, and we identified that rise in October and declared the outbreak in November. And Louisville really had the vast majority of cases until March of 2018. And all the cases, if you look at the epi curve, the cases that were increasing before March, almost all of them had a link back to Louisville. They'd been in jail there, they'd been in substance abuse treatment there, something like that. So really it was a Louisville-based outbreak until around March. And since then, since Louisville knocked their outbreak down, which I'll show you a graph of in a figure in a second, they've had very low incidence. So since November of 2018, they've only, well, maybe more than 16 cases now, but I'm not sure. But it was 16 cases until I think last month, since early November. So very few cases in the Louisville area. They'll most likely experience more cases due to the statewide influence, that there's people coming in and out of Louisville and they're getting exposed in other areas. But the duration of the Louisville outbreak was about 1 year and 3 months, and that's really spectacular because the other urban areas, San Diego and Detroit and Salt Lake City, all were longer than that. I think the shortest one was about 1 year and 4 months. So Louisville did a great job of knocking that out, knocking the outbreak out. But then we got the statewide spread, and like I said, most early cases were linked back to Louisville, and they were prisoners being transferred to other jails or people in substance abuse treatment being transferred to treatment centers. And that's really what started to spread it in the rest of the state. And it initially was only limited to those people, but then there started to be local spread per county around March is when we started to see that. So currently, so we're about 1 year and a few months into this phase now. So here's the figure I was talking about. The blue line here represents Louisville cases. So you can see in March, April, May was where they peaked and then really started going down, and they've been very low since then up to the present day. On the other hand, you see the rise starting as Louisville was going up. We started seeing cases around the rest of the state, but those were really linked back to Louisville until around March, and then we started to see that local spread, and then it just took off like wildfire because it got in that rural drug-using population and spread all over. So now we're down where we are below 20 cases a week, but need to get it knocked out all the way. So in the national hepatitis A virus picture, we were the first to experience rapid spread in these really rural areas, and that's primarily due to the prevalence of drug use. You know, we've known for a long time that Kentucky, Ohio, Tennessee, West Virginia have a lot of drug use in rural areas in the Appalachian area, and that's really what's spreading this outbreak. So once it got into our population, that's where it hit pay dirt, so it could spread really rapidly. West Virginia and Ohio have experienced the same thing as us, and Ohio right now is really going gangbusters. They've got well over 3,000 cases, and they will likely surpass us eventually. Another issue is Kentucky's a home rule state where the local health departments are independent, so we really had to deal with widespread response in that environment, not just the state coming in and doing everything, but trying to work with each of the local health departments on how to address this in their area. So we really had a steep learning curve to respond to the hepatitis A outbreak. None of the other states that had been before us had to really deal with it in this way. Does Kentucky have the worst hepatitis A outbreak nationally? In raw numbers, yes, we're a lot higher than most states. Like I said, Ohio's catching up. But in incidence, the number of cases per population, we're at about 108 per 100,000 right now, whereas West Virginia is at 142 per 100,000. So they've only got 2,500 cases because they've got a much smaller population. In mortality rate, we've done well. We're only at 1% mortality. Michigan had 3% mortality rate. San Diego had 3% mortality rate. That may be partly related to how good we do at identifying cases. So that makes our base number very large, so the number of deaths becomes a smaller percent. But they may be very good at identifying cases too, and they just had higher mortality rates. We don't really know the answer to that. So talking about our response strategy progression, you know, in Louisville, they really implemented a strong incident command system, and we've done that at the state as well. There was a lot of funding for Louisville initially to try and knock it out before it spread to the rest of the state. We did a lot of brainstorming on what strategies to use. We talked to other states, Utah and California and Michigan, to find out what they were doing. Louisville implemented some of their things. They tried all of them. I think some of them worked and some of them didn't because it's a different environment in Louisville. But for the rest of Kentucky, our first strategy was really getting out guidance to the clinicians and local health departments, to you folks, to target drug users and homeless populations for vaccination, identify cases through appropriate testing, and then identify the best targets for vaccination locally. So where do you find those drug users? Is it at the Walmart parking lot or the McDonald's parking lot, or is it a homeless shelter, or is it a syringe exchange program, or hospital ED, jail? So the second strategy then we moved was to tiered funding, where we started offering funding to health departments who were being hit the hardest, and that was based on who was having the most cases, and then on the health department's ability to reach the at-risk population. So you all went through this, identifying plans of where you would reach out to these populations, and finally we based it on projections of need and the ability to reach the at-risk population together. And then our third strategy was having regional meetings. Almost all counties were involved in one of our regional meetings across the state, and those were, I think, very effective to help share best practices and what strategies other counties were using, to learn from the counties that were there, what they had done that worked, and really to focus on breaking down the barriers to get vaccine into the at-risk population. So, and finally, we've had our state vaccination strike team that's been actually very, very active. They've done several thousand vaccinations now in jails and other venues across the state, and that's available for use, although it's tough to schedule because they've got a pretty tight schedule, but that's available for use in the rest of the state. Primary response targeting, of course, we've mentioned this before. Hospital emergency departments see a lot of drug users, correctional facilities, obviously, syringe exchange programs, substance abuse treatment facilities, both residential and outpatient, homeless shelters, behavioral health facilities, and then wherever else you can find a target where you know those populations might show up in larger numbers. And here is a chart I thought you might be interested in, just looking at the number of adult vaccinations given that are in the Kentucky Immunization Registry. So clearly there's a lot more out there than we could document in the registry, but this is what we have. And the white bars are where we don't know the funding source. The purple bars are privately funded vaccine, and then the blue is the public funded vaccine. So that would be through the health departments through the 317 program. And so you see the rates have been very high. I mean, we're talking a couple 100,000. I think when I added this up before, it was somewhere around 320,000 or something total doses that we've given so far across the state for adults. So a lot of vaccine has been put out there in the last year and a half. And this is looking at by facility. This is from the REDCap survey that we did. A lot of health departments responded to that. You see correctional facilities, 25,990. So lots of vaccine given out there. Homeless shelters a little bit less, restaurants, but then other, and I'm not sure what goes into other, but that's the second highest, 16,295 doses. So, but you can see across the board, we've been trying to get vaccine in all kinds of different venues the health departments have. This is our concern, is the map of ongoing transmission. So this is for the last 30 days, those counties that are still experiencing cases. And so you see in particularly South Central and Southeast Kentucky, we still have a number of counties, far Eastern Kentucky, far Western Kentucky, and Northern Kentucky. We're still seeing cases on and off in different counties. And it's just 1 and 2 in most places, but that means there's still hepatitis A circulating in the population, because for anybody who is actually seen and identified as a hepatitis A case, there's probably 10 more that weren't identified because they didn't have bad enough symptoms to be seen by a doctor. So there's still quite a bit of hepatitis A in the state, and that's our concern, is how do we hit this and knock it out again. So we do have these ongoing response needs because we're seeing the outbreak continuing and it's flaring up in places. So what can we do to end the outbreak? Well, we need to identify pockets of risk. Are there groups of people that are still at risk that haven't been vaccinated? And that requires identifying all the cases we can, which I think we're doing pretty well at, and then doing a thorough case investigation so that we can find out what are the risk factors of those people. Is it moving into the MSM population, or is it a different group of drug users that we never knew about? So we need to continue to increase vaccination of these at-risk populations, and to institute the best practices of identification and vaccination of these populations. So hospital EDs are what we focused on yesterday, and if you guys can help with that, to reach out to your EDs again and see if you can get them vaccinating, that would be great. Some EDs are doing it, many are not, but that is really a prime spot to identify and vaccinate the right population and identify the cases. So that's something that we would like to continue to push, is getting vaccination and identification of cases in the hospital EDs. So we had that webinar yesterday. We are really encouraging use of a data collection tool. That's actually, I was a couple minutes late getting down here because I was on a phone call with one of the hospitals who was saying, this form is too much, we can't do it all. How are the ICPs supposed to do this? I said, well, the ICPs aren't supposed to do it. It's the hospital ED personnel. They just need to ask the person a bunch of questions and get the information down. So we want to try and get the information on risk factors as soon as they suspect a case, not waiting for the lab confirmation to come back, because like I said before, a lot of these people are lost to follow-up. So if we do that, we can prevent further cases and identify any risk groups to vaccinate. So we're encouraging the hospital EDs to vaccinate also anybody who's at risk. Drug users, of course, are at increased risk for hospitalization and death, so we want to get them any chance we get. That'll reduce transmission in the population, and there are many hospitals that have been able to do this successfully, so that's why we did that webinar yesterday, to share that information. The long-term goal for us would be to implement hepatitis A vaccination for those at risk forever, because if people come in and they're a drug user or they're at risk because they've got alcoholic cirrhosis, anything like that, they should be vaccinated against hepatitis B and C if they aren't immune to them already. So we want to encourage ongoing vaccination. And we also always encourage collaboration with the EDs, with their local health departments, so you guys can coordinate and work with them to bring that about. So when will the outbreak be declared over? I just wanted to say that, just to get the word out there. So the normal way we declare an outbreak over is if there are no indigenous or in-state transmitted cases after 2 incubation periods after the last outbreak associated case. So in this situation, the incubation period for hepatitis A is 15 to 50 days. So 2 incubation periods is 100 days. So if there's been 100 days and we've had no case identified in state that got infected in Kentucky, we will count that as the end of the outbreak. But it has to be shown to be genetically linked to the outbreak if we do have a case. So we will be doing more extensive genetic testing on the last few cases just to make sure, because we can get imported cases from other countries. Those aren't going to count toward the outbreak, or it could be an imported case from another state where we know the exposure happened someplace else. But there may be a new normal, quote unquote, baseline that we have more than 20 cases a year as we've seen in the past, but we'll see. I think for a while we're going to see cases for probably the next couple of years, just because we're surrounded by states that are having a lot of cases. So we're going to have people getting exposed and coming back in Kentucky. Hopefully with the school immunization requirement now and the outbreak itself and the massive vaccination effort we've done, hopefully we've got enough herd immunity to kind of quell this and it won't happen again in any big way. So that's all I've got. I don't know if I did it fast enough, but right on time. All right. So I want to thank you guys and for all your hard work and the stuff you do, because it's really critical to the efforts that we're doing on this outbreak.
So we'll check and see if there are any questions.
Sure. So any questions?
She's looking.
And then that's popped up here.
Well, I'm always available for questions. If anybody needs me, you know where to find me. Dr. White's here. We're all in the same team trying to figure out how to do all this stuff. So let us know if you have any questions.
Paddling in the same canoe.
That's right.
Yeah. Okay. Okay. Well, thank you so much, Doug. So I hope you found today helpful and educational. The only other pieces, so we're going to be ending 30 minutes early today. I'm going to a little luncheon that we're having for Dr. Howard today. The Commissioner's Suite is having lunch with him. So I told them I would, if we could get everything done on time, I would be there. I do want to give some Nurse Executive Council updates. I did want you all to know about the APRN CE conference that's going to be happening September the 24th and 25th at the History Center. This is a project that we started working on when I was first with the state in 2010, where we are offering free CMEs for our APRNs to come for a 2-day session. They can get all of their CMEs done at one time. We are now partnering with the Department of Corrections. They have APRNs who see very similar illnesses to what we see at in our public health work. And so they are partnering with us. So they'll be joining us again this year. And then we are also inviting APRNs that work at the Federally Qualified Health Centers that are going to start doing some of our public health programs that our health departments have been doing, clinical programs that are moving to the FQHC. So APRNs that are going to be working in the breast and cervical cancer screening program, family planning program are 2 examples. And so they'll be attending this and get to know some of their peers as well as get the same education and training. So I'm very excited about that. And it is free to your APRNs to attend. So I hope they are aware of that. And if you need more information on that, we've got a flyer that should have just gone out, but if you didn't get that, contact me and we'll get that to you. The other thing I wanted to tell you about is Dr. Howard came to our last NEC meeting and talked a little bit about the free care program in school health. You probably read about that in the newspaper. We were not initially involved with that. That was a Medicaid program. And then they somehow got around to talking to Dr. Howard about what do you think about this. And so we are now going to be a bit more involved in that. But I felt like, and the NEC felt like that before we started telling people how we think a different program should be run, we need a better handle on how we think school health should be done from the public health lens, not the Medicaid lens. So we had an extra call meeting of the NEC in July. We've got a committee started. We've got Mary Dale Coleman, who is our school nurse coordinator. She's been here just for a few months and has been a school nurse in Madison County. So she's going to be working and reaching out to some of you, getting your opinions and your ideas so that we've got some really good documentation when someone comes to the Department of Public Health and says, well, how do you think school nursing should be done? We've got that document that we can show them. So we're dusting off some really, really really old stuff. We're looking at training. We don't have the capacity to train the folks that we want to train now. If the Department of Education wants to start having school nurses, if they want to do it at the same standards that we do, we're going to have to figure out new ways to train. There's a whole host of issues that we are working on right now. That's not going to be coming out anytime soon, but I did want you to know that we are working on that. So the kudos to the Nursing Executive Council for working on that. So this is the end of our webinar. We'll look and see if there's any other last minute questions. Maybe Sharon can check one last time. And if they're not, I wanted you to know that the PowerPoints that you have seen today will be posted on the nursing office website in the Department for Public Health. If you haven't been there, please go. We have the audio recording of this webinar will be on there, and the PowerPoints will be on there. And we usually can get that done within about 4 or 5 days. Sharon's shaking her head yes. So in about 4 or 5 days, you should be able to send people to this webinar recording and the PowerPoints. Things that you have ideas of what we need to have in our next webinar, please let me know. We will try to get it done early enough that we can get CEUs. I will do my best. I'm going to be at several meetings in October, but we will try to get this all done so that you can get those very needed CEUs that you can apply for. So with no further ado and no other new questions, we will wish you a happy August. Enjoy the state fair, enjoy your vacation, enjoy going back to school, and we'll see you again. And the next, I don't have it on here, but the next one is, I want to say October the 18th, and I don't even have my phone with me, but it will be that third Thursday in October. So we'll see.
The full moon falls on,
Whenever the
I'm
full
sure.
moon, Sharon says that we always do these on the full moon and crazy things happen. So, so we'll see if that happens again. So bye everyone. Thank you for your service. We'll see you in October.